generated from this event will be donated to the Cancer Association of South Africa, Wings of Hope, and Look Better, Feel Better to help them to fund their breast cancer awareness initiatives. So together we can continue to fight this menace. Let us paint South Africa pink on the 31st of October by participating in the Itemba Walkathon all over the nation. Let us build on the gains we have made to raise awareness about breast cancer by ensuring that the message of early detection reaches every nook and cranny of this beautiful country. The link to registration will be displayed on the screen. Without further ado, I wish to invite a panel of esteemed medical experts who will each discuss how breast cancer impacts in various aspects of life. This will be facilitated by, of course, Dr. Molefe. AWON welcomes all of you. I hope you all thoroughly enjoy the discussions and they're enlightening, and we can together make a difference against this menace. I wish to now hand over to Dr. Molefe to start the proceedings. Once again, thank you very much for all your presence, especially the Honorable Minister. Thank you, Dr. Molefe. Over to you.
Thank you, Mo. Distinguished guests, colleagues, friends, activists, members of the media fraternity, our eminent panelists, compatriots from the civil society movement, the society at large, ladies and gentlemen, I would like to underscore, one or two things that Mo has just said. And before doing that, I was going to, make a special a mention of the presence of Mrs. Motshekga in our midst, who we come a long way with. We know she's actually been there as our mother, activist, and leader, and across various aspects of education. But we have developed this relationship to want to see what it is that we could do together in the space of breast cancer awareness in relation to what it is that we could hopefully do together to improve early cancer detection. I wish to point out a few things really just that are in the background as to why this concept was developed, as to putting together an engagement forum of this nature to accelerate this that we want to achieve through this month's activities. We are well aware that despite all the novelties and all the innovations and so much that has been discovered about the treatment of breast cancer still remains a huge scourge across the world. But it is clear that there's a clear division between the first world and the underdeveloped where we are living. It is notable that the incidence of cancer, of breast cancer rather, is notable in the first world, whereas the mortality rates are much higher in the underdeveloped world. So we find ourselves at crossroads as we all still try to grope around ways and means of being able to overcome the burden of the scourge. It is well documented that one of the biggest problems that we have in the world that we live in, which is referred to as the underdeveloped world, is the fact that the majority of cases in breast cancer get detected much later, rather in the late stages of the disease, as opposed to the first world where most of the diagnosis and early detection are in the earlier stages of the disease. So it is clear that there's lots and lots of barriers that are existing, that are facing our communities, insofar as allowing people to exercise, rights and options to access basic care that may enable them to get detected early and treated successfully for the disease. Also, it is well noted that the quality of care is also still questionable in a whole lot of quarters. So we do believe that two key underlying factors to the strategies that we want to develop fully, through this engagement, to involve everybody, that is actively participating in this space, is to try to see how we could overcome some of the existing barriers to, accessing the basic healthcare and amenities that are relevant to breast cancer detection, screening, and treatment. Despite the fact that we are well aware that we are still, at crossroads and not really making that much progress as the world would want to achieve, would strive to make a new investments in certain areas that are probably underexplored, in finding solutions that could actually be able to help us with some of the burning, and notable factors. So we believe that there's reason for all of us to do more, to invest in research that could assist to be able to pinpoint some of those sectors that might be at play to derail all that is desired by our communities to improve, healthcare outcomes in the treatment of breast cancer. It is for that reason, therefore, that we thought it expedient that if we are going to talk about early detection of breast cancer in relation to this breast cancer awareness month, which is October, we should not only harp on the fact that it is important to go out and screen and get breast cancer detected early, so as to get better results, but try to focus microscopically on some of the factors that are at play that might be derailing this desired desired outcome by all of us. And it is for that reason that we decided that we've got to focus on a few topical areas that might be at play, that we think they might be able to talk to some of the issues that are relevant, and might perhaps be contributing towards derailing or service barriers, but at the same time that they could stand at a sore point. At least there may be areas that we could focus on in terms of developing strategies as we sharpen our capacity to work towards overcoming some of the challenges that we have in relation to solving the breast cancer conundrum. So we have identified 4 key areas, and we then invited notable eminent specialists, medical specialists, that could be able to talk to some of these areas, and namely we decided to focus on the emotions that are relevant to breast cancer screening, because we believe very strongly that that is on its own a key barrier to detection and receipt of care. So we would have Dr. Dala presenting that topic, followed by a talk from Professor Ben, who would talk about the surgical treatment options that are relevant for managing early breast cancer. Followed by Dr. Ngidi, who is a Johannesburg-based oncologist, that would try to sum up a few factors that are related to what the issues that are burning in relation to chemotherapy and radiotherapy, in particular reference to early breast cancer detection. And then last but not least, is going to be Professor Ndobe, who is a plastic surgeon. He is going to talk about how breast reconstruction fits into the midst of it all. Without further ado, I would like to call on Dr. Talatala to come to the fore and engage this topic of the impact, the negative impact of emotions or personal emotions on breast cancer screening and hence early detection. Dr. Talatala, good morning.
Morning to WFA and morning to all the guests. I think it's been inappropriate for me not to recognize the Minister, Umama Orange Mutseha, specifically amongst all guests. So don't all feel bad that I didn't mention everyone else by name. Thanks to you, to the Minister, for inviting me again this year. You had invited me last year when we were at Makonya Mall. Thanks for inviting me and including me in this important project that we are pursuing with everyone. And thanks to them for continuing to sponsor. I would like to bring to the attention of all the guests that this International Breast Cancer Month coincides with 10th of October, which is the World Mental Health Day. So it's an important month for me, and I think I actually like the fact that the coincidence and the overlap. I noted the time. I'm just going to make a few points. Hopefully, I won't take more than 5 minutes, so that there's enough time for us to discuss and not be too long. When we look, firstly, before I even talk, most of the information that I have, I must always thank my patients, is from reading, but I don't think reading is enough. I think the experiences with interacting with patients, they enrich our lives, and we should always be grateful, especially us in the mental health care space, because we tend to go into people's private spaces and explore their emotions. So when it comes to screening for cancer, or in fact, for that matter, for any disease, but today we're focusing on cancer. There's, the social, economic, and social reasons why people will not screen. But I thought today we should actually just focus on the psychological, the emotional stuff that will make one not to screen, or make it difficult for them to screen, or later on to accept screening and move on. So I'll just mention a few points. Firstly, there are people who are not aware. That's why we have this project. We need to actually get people aware that there is breast cancer, there is screening from it, and there's benefits to early detection of cancer and treatment. But once people are aware, in their own minds, they then calculate what is my risk of getting this disease. So if they calculate and think that it's less likely that I'll get it, they are less likely to go and do any screening. Or if they calculate in their heads and realize, oh, if I screen for breast cancer, I'm screening for the worst disease. It's fatal. My death sentence. Who wants to know about their own death sentence? So then people will then avoid screening because they've calculated in their head that they are at risk, and if they get the disease, they probably die because the treatments are not effective. I'm not saying they're not effective personally, but they are processing that in their heads. So those are early emotions of screening, and then the calculations that one processes through their heads: death sentence, or my risk is low. Then once they consider screening, assuming that now they do consider screening, then there's the fear of the process of screening. And there could also be less acceptance of it, or even embarrassment of the consequences of screening. Remember, the screening starts with the breast palpation, which people need to be taught on how to do it, but it also evolves to stuff that is done in hospital, mammography. And what I know, as doctors may take it lightly, that I've heard of patients that are actually scared of even going to hospital. It doesn't matter what the hospitals are about. They're scared of the smell of the hospital. Hopefully they will improve now. The fear will get less now with the COVID and people having used so much of the sanitizer. But there's a fear of even the institution itself and the process of and knowing that If breast cancer is found, you have to go to theater, sessions where you have to do an operation, you have to go through oncology, and then there's side effects that go through. So whilst the fear may be good and can motivate one to test, if I know that there's family history, I may be anxious, and actually studies have shown that fear of breast cancer can motivate some people to go for testing, but fear can also be negative in the sense that it may make some people to not want to test, to procrastinate screening, or to even be in denial that they can actually even themselves get the cancer. The last emotion that I want to mention, and we can discuss this in detail even later, is the embarrassment. There are people in our communities that think that even the having cancer is an embarrassment to the family. Even when someone is diagnosed with cancer, you should not actually talk about it even amongst family members. But now with breast cancer, remember it also involves a private part, which is the breast, and also the diagnosis of the cancer itself may have an effect on the relationship between the partners. So there could be embarrassment about what's going to happen to my breast, all those emotions that have to do with that. What is important as the closing line is that I think what is protective to all these emotions that I've mentioned is the availability of social support. Social support in the community and general awareness of the illness, but also support within the family and within the partners. Breast cancer, we always mention, sorry? One more last, I know that I forgot my name. We always mention women, but the awareness is even worse when it comes to men screening for breast cancer and screening for even more cancers. Thank you.
Dr. Talatala, thank you very much for that introductory insight into the emotions around the screening of breast cancer. Having been a practitioner myself and dealing with a lot of patients out in primary care, I do know that anxiety, fear, and a whole myriad of emotions do play a very important effect on cancer, on healthcare broadly. However, we were also aware that emotions might play a positive role as much as they do play a negative role on doing that which we would like to happen to ensure that people get access to what they require. What would your comment just be, just very briefly, just in closing? What do you think are the positive aspects that might impact on an individual to keep on their toes and at the edge of their seat and ensure that they don't just disregard a lump in their chest, and instead they will go out and seek care from the GP down by the corner?
I think one of the most important things is knowledge. Once people have the knowledge, then they, even if it provokes some fear at the beginning, then they can process it, the fear or the anxiety in their knowledge. I mean, in their minds. They must have, if they can share the knowledge that there is screening, the screening can detect the cancer, there is treatment, and the outcomes over the years with early screening and intervention have improved, then that will make them to be less anxious. But you do need a little bit of anxiety, otherwise you'll ignore it, not do anything. So that little bit of fear is also good in the sense that it then encourages you to actually go for the screening and actually go through the process. If you have no anxiety, no fear, no emotions at all, you could actually ignore and not do anything about the knowledge you have.
Fantastic. Just before we close this, this discussion around this first topic, I would like to invite the Minister, just very briefly, Minister, if you'd allow us, just to indulge us a bit as to what your outlook is on how we collectively as society can contribute towards improved breast health in schools.
No, thank you very much, Doctor. And let me thank the previous doctor because it was as if he's reading my script. So he spoke about all the things that I went through. First, the denial about, I had enjoyed good health all my life. And when I felt this lump under my armpit, it just didn't even strike me that it could be breast cancer. I was encouraged by my cousin sister, who was a doctor, really just said to me, you have to go and see the doctor. And nothing, it never even dawned to me that it would be cancer. Well, still, I used to be a volunteer for women who had cancer. We used to go and assist them, but it never dawned to me that I'm a woman like them and could develop breast cancer. It took me almost a year to own up until my oncologist said, it's either we go through the treatment or we have to cut ties because I'm not sure what more he wants from me. And that helped me to really confront it finally when the doctor insisted. It was almost a year, I was just refusing to accept that myself. I don't feel the pain, I don't feel anything, but there's this lump which is busy changing shapes. Doctor told me that it was cancerous, but I just felt that, you know, it can't be me. I'm still feeling very healthy and I'm still feeling very strong. So what really, I think what would assist doctor to a very large extent, it's exactly dealing with the emotional part, because until I really had to fight with my oncologist, I just was in complete denial. And especially young kids, they're unlikely to believe that they would have a lump that is cancerous because it's as if it's for other people. It only, as I said to me, I was assisted by the fact that I used to volunteer and work with women who had cancer as a gender activist. And that helped me to remind me that I'm a woman like them. So I think for me, that's for one of the key things that now is driving my life to say, let's go and speak to these people. Say it can be anybody, it can be any age. You have to test, and if you don't, like my oncologist used to tell me, it's going to be more disastrous. And also with families, and it took me time to tell my husband because it's not even the shame that was. He's such a soft, caring person, and I knew it could really wreck him if he really saw me as a dying wife. And I thought I was protecting him. I stay with my aged mother, and I know no mother wants to bury their children. So I was really worried about everybody around me except myself. But it was only when I remembered that I'm a woman like all the other women who had gone through breast cancer, and it can happen to anyone. And it just gave me the strength to confront it and deal with it. So that in schools, it's just that awareness to say it can happen to anybody at any time. It doesn't, I don't have a history of cancer in my family, and that's why I was in denial. I always had enjoyed good health. And nothing just said to me, I will have cancer. But the awareness, and I think the thought and the support that I got from doctors assisted me to be a survivor today, because with my denial, because I said to the doctor, I'm waiting to be sick. I can't go for this very invasive treatment of cancer, have my hair falling off. You might even advise me to cut my breast, and doctor, I just don't think these things add up. I'm not sick. So why should I really go to chemo? Why should I go to surgery when I don't feel anything? But again, just to take people through those emotions. That's why I said the first doctor just thought it was like he's reading my script. And that's what I think for me is the first step of getting people to accept that they're women, like it can happen to anybody at any time. And that treatment, chemo difficult as it is, now I have 10 years since I survived breast cancer. So chemo took me not more than 6 months, but I've had benefits of 9 years to really continue and just even help people to balance out. So I don't want to take much of your time. The doctor has spoken. He's read my script about the emotions around breast cancer. Thank you very much for the opportunity, Doctor.
Thank you, Minister. Just in closing, but in relation to this very important topic, I'd like to call on Zonke Mngunu, who plays the famous, part of Iman in, a popular soapy production called Muvango, that we've watched over the past couple of months. looking up after, a spouse who's living with terminal disease, and has impacted amongst, upon all of us, the role that a family support, could play in ensuring that an affected individual could be able to ultimately reach the desired good outcome. So, Zonke, just after what Dr. Talatala has presented and the input there by the minister, and from this massive role that you're tasked with at Muvhango to play out this supportive character, but in a sense also being an ambassador for family support for cancer survivors, in your message to the community, what would you be say, just as a comment, just very briefly to that, please?
Okay, I greet everyone. Just like the minister said, I also don't have any history about any cancer in my family. My first time ever being exposed to such a topic was when I had to play this character, and then this woman has a fiance, and he is suffering from a cancer called leukemia. So when I was researching about this particular one, it was like really hard for me, because when I saw the symptoms, they said the symptoms were like flu-like symptoms, of which many people wouldn't even take notice of it. So going on, it was really, really hard for me, because I was imagining myself playing this character, having to care for this person. It's like you have to find yourself in a new role, whether you're young or old, because cancer is very sneaky. I can't really imagine what other people go through in real life in order to support the kind of emotions and feelings that they go through, because for me, it was sadness, it was anger, it was grief, guilt, and loneliness, because it's this person, you've been living with this person, and then suddenly there's this cancer hanging around you guys, and then you have to fight it. It's hard, because you have to be strong for that person, hold their hand and help them through it. So playing that character really helped me a lot, and it was easy for me because I had to snap out of it very I was just wondering, what do other people go through where they have to stay with this person and nurse this person? So yes, it was really hard. It's really hard, and also growing up in like rural areas, as Ubaba Molefe was saying, that there are areas that are underexplored, and people that don't have enough information when it comes to cancer and all of that. So I'm hoping that, especially in rural areas where there are not a lot of resources to gain information on such topics, I'm just glad that there's a platform like this that can teach and give awareness about breast cancer. Thank you.
Thank you very much. Zonke, I really appreciate that. Sometimes we struggle remembering whether we should refer to you as Iman or Imani, or refer to you as Zonke. As I would have underscored, I am Mulifi. I come from an organization called Genesis, which is a non-profit entity that strives to improve the lives and contribute towards people that are affected with the breast cancer. And it is indeed an honor that, Yvonne has extended his outreach and lended a hand to ourselves, as well as the other partnering NGOs, to work together towards this cause. I wish to acknowledge the presence now of Professor Carol Ben, a well-known surgeon and breast cancer expert. I've been on panels with her discussing the subject, and I've always just been awed with her immense knowledge. And she's contributed a whole lot to the lives of a lot of people that have been affected by this disease. Prof, welcome. Professor Ben is based at Helen Joseph and runs a breast cancer clinic there. Prof, we have invited you to join us this morning just to give us a short insight, just as a teaser, I suppose, as it were, on exactly the role of two major well-known surgical options or treatment options rather for early breast cancer, namely a lumpectomy or a mastectomy. Would you just give us just an overview of why this important and their role in your practice, and how they've done to impact on improving the cure rate, and in fact improving the outcomes of a whole lot of early breast cancer survivors. Over to you, Prof.
Hi there. Sorry, can you hear me? Sorry, my name's Ron. I'm just Prof's PA. She's, I've let her know to come. She's coming just now. She's just sorting out some patients, but she knows she's going to be here in a few seconds. Sorry, it's a clinic day.
Okay, that's fine.
I see her. She is right here.
Oh, is she there already? Okay.
Yeah.
Then I think in the flow of events, it would actually have been quite critical that she, we just give her a minute to sort of settle down. To say
here's Prof. Ben for you.
Okay.
Right. Hello, everybody.
Hi, Prof. Hi, Prof. How are you?
I'm very good, thank you.
Welcome. Everybody has just been waiting to hear you once more. Give us a brief account of the gospel around successful treatment of early breast cancer. And we know you're quite busy, and thank you for allowing us to pull you out of your busy clinic practice at the hospital. But Prof, can you just give us just a very short, brief overview as to the role of the two major surgical treatments for early breast cancer, namely lumpectomies and mastectomy, and really the why and why they should matter for anybody that is just agreeing to want to get tested and screened and perhaps maybe get diagnosed with breast cancer, to know that they would matter a lot and possibly that they might end up getting either of those treatments.
So thank you so
also
much.
which one would actually matter more under what circumstances? Very briefly, for this type of setting. Thank you, Prof.
Firstly, thank you for the invitation, and it's good to see my lovely friend Lillian looking gorgeous over there. Okay, and I think I just want to start off by saying that breast cancer is neither ageist, racist, or sexist. And Lillian, you're an inspiration, and never mind your YouTube about the boys checking out. We must all check our breasts, all our body parts, because the most important thing is that anyone can get a breast cancer. I've just taken a youngster who's 29 to the counseling rooms with a big advanced breast cancer. So we see cancers at all ages. This is my big Helen Joseph clinic, and we have lots of patients here today. So it affects all of us. So we must first take away the fear, the fact that breast cancer can be treated, and we have our beautiful Madame Dubé as proof that you can not only beat this once, you can beat it twice. And what we want to say to people is the diagnosis of breast cancer is not made in the hands of the surgeon. It's made by going for mammograms and ultrasounds and needle biopsies and taking time around decisions and choices. So consent in medicine is very, very important. So there was a very interesting thing by our government recently about the fact that a mastectomy is tantamount to gender-based violence. And I think that what we need to know today is that very few people need a mastectomy. very few. So if you look at the international guidelines, okay, there are only 3 scenarios with the breast cancer where people need a mastectomy. I'll make that 4. I think the important one is patient choice. And the first thing someone needs to realize is taking off a breast or taking out a cancer is choice, but cancer doesn't run around the breast and it doesn't jump to the other breast. If cancer is wanting to kill people, it spreads elsewhere. The next thing is there's a type of cancer called an inflammatory cancer, which is a big red breast, and all of those, after needing oncology, chemotherapy first, need a mastectomy, or obviously if there's cancer throughout the breast. It's a bit like saying if there's COVID throughout the world, there's COVID throughout the world. So why we say people can't come and travel, I don't know. Okay, but that's another story. It's nice to see Prof. Ndobe. Is that my good professor friend? The best professor I know. Okay, good. Okay, beautiful hands. Okay, very good at reconstruction and breast reductions. Okay, so the fact of the matter is it's choice. So what you want to do is diagnose breast cancers early. We treat breast cancers in terms of their behavior. So there are different types of breast cancers. It's a bit like saying TB is different from malaria. They're treated differently. So you work out what type of breast cancer it is, and then you offer treatment accordingly. So not everybody needs chemo, okay? But what you've got to do is you've got to counsel people around their bodies and what's going on. And what we want to do is take away fear. So I commented on the radio this morning, people are not ignorant. You know when you've got a lump, and you know when you've got a sore foot, and you know when you've got a headache. It's about fear. That means the reason why people don't come in. So we want to take away that fear concept and understand that if you know what's going on, then you can manage it. Then you can make informed choice decisions. So we want to make a diagnosis, to counsel people, which is why we have so many counselors, both people who've been through cancer treatment and trained nursing sisters and volunteers to spread, as you mentioned, gospel, the good message. Stay away from those, what I call hairdresser mentality, alarmists. Oh my golly, I'm so sorry you had this, my auntie died, my this died, my that. So I have a big concept for me, particularly in this country, is promote the positive, okay? There's lots of negative. Being diagnosed with a breast cancer is not something anyone wants, but promote the positive. The fact that, yes, you can manage it, make sure you surround yourself with families and friends, promote exercise. That's why this online walk and these things are so important, because we know that whereas 65% of all people who get breast cancer have no risk factors, what we do know is there's benefit in watching our weight and benefit in exercise for decreasing cancer risk, and in those people who've had cancer, in making sure that there's less chance of cancers coming back. So what we want to do is say to people, know your body, okay, try and do what's right by it, go and have your treatment done in a multidisciplinary environment. And I'm very proud of the Helen Joseph Clinic, because we have a very good plastics and reconstructive team that works together with us, and a large number of our patients can have the option of breast reconstruction. Okay, you can have reconstruction if you've had a big cancer or a small cancer, but what you always want to promote is safe cancer treatment. So safety first. Understand that a lot of times we still see 65% of our people coming in with advanced cancers. So what the media needs to do, and particularly awareness platforms like this, is to promote that people come in earlier. So if you've got something, don't be scared to come in. And healthcare is a fundamental human right. So you can get excellent equivalent care in good government units that you can in the private sector. And it's not about having money means better treatment. I think what we must realize is that you go to a multidisciplinary environment, you take time, you speak to the doctors, you ask questions, and you go one step at a time through your treatment. Okay.
Thank you, Prof. Prof, do you think that increasingly now that we are all aware that the whole role of decision-making in cancer care is so critical, that there's now a more formalized manner in which your patients are being empowered to become part of that decision-making? as to what it is that you're suggesting to them?
Absolutely. I think medicine is no longer vertical medicine, it's horizontal medicine. It means that it is your body, not the doctor's body. It's your temple. So what we need to do is we need to promote people being involved in their healthcare. Obviously, the doctors are going to give you best advice in terms of management, but again, you're entitled to second opinions. Stay away from people who can tell you we cure the world and we solve the world's problems and everything, because no one can. Okay, life's not easy and it's one step at a time, but make sure that your treatment is within a multidisciplinary environment, and make sure you surround yourself with a good team of close friends, counselors, and you are absolutely entitled to question doctors and go through process and take time. Breast cancer is not it's not flu, okay? It doesn't arrive one day and gone one other. This is a life-changing event. So you want to take time in going through all your options so that you can have some form of consent, because that gives you some security in managing your healthcare. You may not be able to change the diagnosis, and you may not need to be able to change the road that you're going to have to travel. But what it does is it gives you an idea of the journey, and it gives you where you can take little stops and who you can take with you along the journey. And I think that's very important.
Thank you, Prof. Just at that point, I'd just like to call on Mrs. Neo-Lisela, who is a breast cancer survivor. And I'm sure you'd love to hear what she has to say, because I do know that whatever choice she exercised at the time when she was busy engaging with treating doctors has really worked very well, and she's remained pretty over the years. Mrs. Lisela, I am aware that you opted to do a lumpectomy at the time when you're given various options. In just very quickly, because we're really running behind time-wise, what really informed you? I know the doctor might have taught you and given you a lecture around that, or you might have gone to inquire. But just in a summary, what is it that made you comfortable that you should choose the way you did and have not regretted it since?
Good morning. Thank you for the invitation, Dr. Molefi, and good morning to the rest of your panelists and your guests. So very quickly, I was obviously given the option to have a full-on mastectomy or to have the lumpectomy. But fortunately, in my case, because my cancer was detected early, I decided to take advantage of the benefits of early detection, which gave me the option of going for a lumpectomy. Dr. Ben already mentioned that, it was very much made clear to me that it is my choice whether I wanted to go the lumpectomy route or the mastectomy route. And I just felt that, because I was given the opportunity to make my own decisions and I had agency over what is going to happen to my body, I then decided to go for a lumpectomy, because fortunately in my case, like I said, my cancer was detected early, but I also had an excellent response to chemotherapy, and that actually even made my case stronger regarding why I wanted to go for a lumpectomy. Even though, some people say that when you have a lumpectomy, there's a chance that the cancer might come back, but I was very confident in my choice, because one of the reasons why my cancer was detected early is that I'm extremely vigilant in terms of doing my breast exams. So I had the comfort of knowing that, should heaven forbid the cancer decide to come back because I opted to have a lumpectomy instead of a mastectomy, that I'm very confident that I would once again find the cancer very early on. So those really were just the reasons why I decided to opt for a lumpectomy. Not to mention, obviously, just to make the moment like that, it was also from a vanity point of view. The fact that my oncologist was confident that I could easily survive with a lumpectomy, I obviously decided that I would rather opt for that than to lose my whole breast.
So I just going to want to comment on that, because I think it's very important. So cancer doesn't come back in the breast. If it's going to come back, it wants to come back elsewhere. So we do always have the exceptions, and my lovely friend Lillian will be the exception, where she had 2 different types of cancers, okay, in the same breast, but that is very uncommon, okay. So the fact of the matter is, it's not about coming back, it's about, you can get a second cancer, but it's no different to the fact that I'm a blonde in Africa and we probably shouldn't be here, which means I have dodgy skin and every now and again something has to be cut out. I can't take my skin off, so I just have to
Sure.
be vigilant and that type of thing. So the fact of the matter is, you're right. You know, a woman's breast is a very personal thing, and you had your chemo, you've had a good response, and if the cancer's in one area, then whether you start with chemo or afterwards, you can absolutely do the breast saving operation.
Yeah.
Thank you, Prof.
Okay.
Thank you
Thanks,
very much. Could I please just highlight to everybody, please, that should anybody have some comments to make or a question, you know, they could be made through the chat box, and Hawking, who is working with me to ensure that this runs smoothly, will be able to capture that, and we could respond at some point. Unfortunately, we're running late, but hopefully there might just be time to respond or to revert back. But thank you very much, Prof. and Mrs. Lisela. I'd now like to call on Dr. Ngidi. Dr. Steyn Ngidi is an oncologist who's based here in Johannesburg, is working at the Landmark Hospital and the Lesedi Clinic. And we've asked Dr. Ngidi just to give us just an outlook on, you know, the role of, a chemo as well as radiation in relation to what we strive to do, which is to improve the life of as early detected breast cancer, patients. Dr. Ngidi, good morning, and thank you for making it in your busy schedule. I know you run a very big practice, but how and what do you think are the key elements to focus on, that is in the two aspects of care that you're involved with, mainly in your busy oncology practice, when you deal with early breast cancer, and what type of treatment choices, or rather what's your approach to guiding your patients in terms of the different treatment choices to make on either front? Very briefly, please.
Okay. Thank you for inviting me, and thank you to my colleagues as well as to all the guests. This is a very important journey that a patient goes through when they get referred to the oncologist from the surgeon. So I always start off with an analogy that you are running a race. So you've started running from the surgical perspective, and now you've moved on to the next person in your care team. For me, the most important thing is empowering the patient and knowing that they are not powerless. It's not the cancer that's in control, neither it's the doctors, but it's the actual patient who is going to run the race. Your specialists are there on the side to sort of give you maps and give you different options of the type of treatment that you have, but it's actually you who needs to run the race. And choice is very important. So when you come to us, we give you a number of options of treatment, and all this is based on your diagnosis, the type of cancer that you have, as well as your surgical results as well. There's chemotherapy, there's radiation therapy, as well as there's hormone therapy, and they can be sequenced differently. And even at times, if it's early breast cancer, you may not even need chemotherapy, you may not even need radiation therapy, you might just maybe move on to hormone therapy if your cancer is hormone sensitive. There are certain tools that we use to decide or to assist you in making the choice of which treatment you would like to go to. Evidence is very important in scientific knowledge, and we also use other tools and algorithms to decide which is the best choice. And as Prof. Ben correctly said, it has to be a multidisciplinary team where we all give input to help you in deciding on the choice. I think a very important aspect is having someone who's a cheerleader with you as well in your team, be it a family member or one of your friends who comes with you for these treatments, who comes with counseling. So we can all have a conversation, but someone to just guide and cheer you on as you are running your race. there are many aspects of the treatment which the patient can actually be in control of, like habits, like eating well, exercise is very important, as well as good nutrition, because all of those tend to minimize side effects. And the psychological well-being and emotional well-being. So I always say you are not just flesh only. We're not treating just flesh, meaning your body with breast cancer, but the mind and the soul as well needs to be treated as well. So that's where we have psychologists with family coming in as positive reinformants, psychologists. So treatment does have side effects. So how we decide on the type of treatment that you should have is based on your stage of cancer, the behavior, the known behavior of your cancer, as well as we look at you as a patient, how old you are, what are your aims in treatment, what are your goals, what are your wishes as well, where do you live, how often can you come for treatment. And we also look at the side effects profile of each drug to see which one would be more suited for you. Because as Prof. Ben correctly mentioned, toxicity or side effects is something that's important. There's no point in giving you treatment, but that's going to harm you and make you feel even worse than what you felt before. So with chemotherapy, I find there's a lot of fear. Most of the time when people, before they even come to you, they've listened to everybody else telling them about bad experiences or this one died of treatment. And I always say, cancer is very unique. It is your body, it is your cancer. One person, the way they react to treatment is not the same as someone else. Everything is individualistic and unique. And I always say it's 2020 now. The treatments are better. We know as well that sometimes you don't need certain types of treatment as well. So chemotherapy kills all fast growing cells. The thing is, it cannot differentiate what is cancer, what are normal cells, because there are normal cells as well that are growing fast. So chemotherapy will kill all fast growing cells. So some normal cells that do get affected is hair. Hair is one of those cells that grows very fast. So you'll find that people lose hair. And often that is a big concern. And we often say that hair can grow back. And there are some agents where we can pick an agent that might not make your hair fall. There's also radiation, which is what we do as well, which is a part of oncology treatment as well. Generally, when we sequence treatment, we decide chemotherapy will come first and then radiation. So when you know you're on the radiation phase and moving on to the hormone phase, you know that you are on a good run and you can see basically the finish line. Our role as specialists is always to give support, and knowledge is always power. And also even knowing what type of side effects as well you can expect. It makes it easier for you when it does happen, because you know exactly what to do. So for example, like nausea and vomiting, we often say do not eat spicy foods that are full of oil and fat, because that can make you want to vomit as well. So there are many different treatments with many side effects, but what I have found as an oncologist, which really empowers the patient, if they have made a choice and said, I own this, and I'm the one who's directing treatment and where to go, they tend to fare quite better and well, and even in terms of side effects, because when it's early breast cancer that's caught early, victory definitely is something that we push towards. Thank you.
Thank you very much, Dr. Ngedi, for that insightful response, giving an account on that very large topical area of chemotherapy and radiotherapy. It was really just a teaser in terms of to get an outlook in the approach to it. But I would also like to ask you whether you'd find that in your practice you have a lot of resistance from patients that have already been, let's say, maybe received one treatment modality like surgery, and now you recommend that they must get adjuvant therapy with chemo, let's say mainly chemo from a side effect point of view, and the patients would tend to think, well, I mean, if I had to do surgery because early stage? Is it necessary for me to do chemo? Because we do know there's a lot of people that tend to think that chemotherapy is normally reserved for late stage cancer.
Yes, no, we do use chemotherapy in early stage breast cancer for certain cancers who show a biological behavior, or if maybe the cancer couldn't be resected completely based on histology. I think as well, education is very important, and knowing the different side effects, because sometimes you do experience side effects. It's always important to empower the patient so they can also make a correct decision as well in terms of the treatment. We do definitely sometimes do need it, but most of the time we don't need it. So for my part, it's always education, education, education. And remember, everything is so unique to everybody else. Someone else's symptoms might not, side effects might not be your own. And also just knowing that, yes, side effects do occur, but there are treatment processes that we can utilize. For example, if your immune system goes down, we have agents that we use as injections, or even maybe just saying, maybe you just need a break. And that's why chemotherapy, we sequence it in such a way where you call it cycles, where there are days where you don't get chemotherapy, just to give your body enough time to recover. But there are also other agents which the patient can use, which is in their control. For example, making sure that you eat well nutritionally, you rest well as well, making sure that your food choices as well are very important that can help you through. So we always identify and find ways in which the patient can also empower themselves and feel in control.
Thank you very much, Doc. In summary, I would just like to invite Mrs. Tlaki Nyatumba, who's a survivor, just to briefly, I know we are very terribly pressed for time, Tlaki, but I think we would benefit from just hearing from you whether at the time that you are coping with your disease, do you think that you were empowered to know what it is that you do to monitor the side effects on a daily basis? I've seen some of your pictures at the time when you had hair loss and this and that over there and lost a lot of weight. Just briefly summarize, do you think you had a plan as to how to manage your side effects?
Yes, good morning, everyone. Yes, Doctor, I felt very much empowered because fortunately, my team of doctors that were taking care of me, they really did well. They were very, very diligent into introducing me to the journey. And as it's been mentioned by the doctors that it's a journey and you have to be willing to undergo the journey, take up the race. With me, I adopted the spirit of malignancy. I know that the doctors will know that there's what they call the benign stage and the malignant stage. And sometimes it helps you to approach the journey and the race with the same spirit of malignancy, to say that, you know what, I'm going to fight this thing fire by fire, and not succumb to the news that you are being diagnosed with this and this is your finality. No, you should treat it as a journey, and I was very much empowered because the decisions were left with me. I was given the information and said, look, you've got the decisions, and I've heard the doctors mentioning it, that there are processes, and Dr. Ngidi has just mentioned as well that even with the undergoing the chemo, you are not thrown into the deep end, the ocean, to just swim endlessly. You are given breaks, a fair amount of knowledge to say that, look, we are going to give this to you with cycles, and these are going to be the cases, you're going to experience this. And yeah, I really did felt very much empowered, and as a result, I took
And very
the
well.
journey with gracefully, and there I am. Yeah.
Now, thank you very much. I mean, your story has actually been very inspiring. Thank you very much for your input. Now, there's a big topic that we want to get into, and we know it's a giant in the room, but we would hope to get out of listening to Professor Mdobe ask, answer just a few questions and say a number of things about breast reconstruction, just have to guide us as the general public as to what the issues are really in relation to early breast cancer detection. Professor Mdobe is the head of plastic surgery at the University of the Witwatersrand Teaching Hospital Complex, and he does quite a whole lot of work at different the clinics and hospitals, and we really are privileged to have him this morning, and we really would like to thank him for taking time just to come and share this moment as we mark this important journey of starting this month of breast cancer awareness. Professor Mdobe, we have been talking a whole lot about a surgical treatment for the early breast cancer patient. And Dr. Ngidi has just eloquently given us a sum up on the role of chemo and radiation therapy, particularly in an adjunctive role, and to have to deal with issues pertaining to side effects and all of that. But as I said, the bigger elephant in the room is still that a lot of people, when they are told that they've got to go to hospital, go get their breast cancer treated, they get worried that they're going to lose their breast. What's your overview towards how we should be throwing out, a message to the prospective patient that ending up with a breast cancer, ending up with a removal of the breast is not the end of the world?
Good morning, Dr. Molefi, friends and colleagues. I wonder, can you hear me?
Yes, we can.
We can. Yes, thank you very much for giving me this opportunity to brief you on breast reconstruction. As I've heard, there are many issues, in breast cancer. We have dealt with the psychological impact of the diagnosis, So when we come to surgery, there's also big issues, especially psychologically. In the past, and the long past, breast cancer was equivalent to a mastectomy, but that's not an issue today. So today we practice what we call breast conserving therapy. Actually, one of the panelists, Prof. Ben, is one of the proponents of breast conserving therapy, which means that we don't actually aim at removing the entire breast. We can take part of the breast, or a lumpectomy, as has already been alluded to. So there are many factors involved in breast reconstruction. Firstly is the patient wishes, the tumor pathology, genetic factors like family history, sisters, aunts, mother, grandmas, have they been involved? Are they survivors of breast cancer? Or, in short, family history of breast cancer. Most patients decide actually whether they want a reconstruction or not. Some patients will say, just get rid of the breast. I don't want to hear anything anymore, because they believe that a mastectomy equals a cure. But we know today that the mastectomy is not equal to a cure. Wide local excision plus radiation therapy equals a mastectomy. So which means you can't keep your breast. So there are various methods for breast reconstruction. You can use your own tissues. We can use implants, that is tissue expansion and breast implants. We can use the same breast tissues. using wide local excision in a breast reduction pattern, removing the cancer, and actually doing an equalizing procedure for the left and the right breast so that you don't walk around lopsided, you know. So many women find mastectomy devastating and disfiguring. And losing a breast, you can actually lose friends, you can lose colleagues, and more importantly, you can lose your spouse as well, you know, because of losing a breast. Women feel less feminine after they've lost one breast, you know. So it's an important part of the body that have to be respected. So what we do, we advise the patients on the most appropriate way of removing the breast cancer and doing the reconstruction, you know. So if the cancer is small, like early detection, a wide local excision or a lumpectomy will do without disfiguring the remaining breast. If the tumor is bigger, we use other means. We can actually excise the tumor and reconstruct with the patient's own tissues. We can take muscles from the back, can take muscles from the tummy to reconstruct the breast. But in cases where we find that breast reconstruction cannot work in this particular patient, either because of the tumor pathology, the extent of the spread, and other comorbidities like severe diabetes mellitus or hypertension, or retroviral diseases which are uncontrolled, you know, with a low CD4 count and a high viral load. In that case, we rightfully advise the patient that the best option for you will be a mastectomy. And in that case, we don't only do a mastectomy, but we also make the other breast smaller so that the difference between the two sides is not that much, especially in clothes. So in short, I would say breast reconstruction is there. We are there, and other colleagues are there who are doing breast reconstruction. So breast cancer doesn't mean that you're going to lose a breast entirely. So there are means and ways of saving the breast, and which is key nowadays that we aim at saving the breast. You know, if the worst come to the worst, we have to remove the whole breast. There are ways of reconstructing the breast, you know. And either
Thank
before
you, Prof.
or yes.
Sorry to have interrupted you. Yes, you're finishing off, Prof? Yes.
No, I was just saying that again, as we also involve oncologists like Dr. Ngidi to advise us whether this patient will need radiation therapy or not, because that's a factor as well in reconstruction. Do you want to irradiate reconstructed tissues or not? So I'll stop there, Dr. Molefi, because of time issues, but I think I've given a brief overview of breast reconstruction.
Thank you, Prof. But, you know, before we close off this very important and exciting chapter, how do you empower your patients in general, or, you know, everybody that is caring for people that are anticipating possibly a reconstruction or that would have already gone for, you know, a reconstruction procedure, as how they should actually be monitoring the quality of their life post a reconstruction, quite simply in the home, really not in the practice.
Yeah, so what we do post-reconstruction, patient must carry on with breast self-examination, actually to detect early recurrence. When we do implant breast reconstruction, we actually advise them that implants might have problems, like what we call capsular contracture, that is hardening of the breast, and pain, you know. But again, we have regular follow-ups, you know. Every 3 months, patients come back to the clinic and we check them to make sure that the reconstruction is going well and there are no early recurrences. And if there are any problems like wound issues, we take care of them. And that's very early in the process where we make sure that wounds heal well and the patients are happy. So we don't just do the reconstruction and send them away, but we have a regular follow-up. And again, in our clinic at Helen Joseph, they'll not only be seeing us, they'll be seeing Prof. Ben as well.
A very important one, just very quickly, how empower patients to decide after a mastectomy whether they should have an early reconstruction or a delayed reconstruction?
Okay.
Just in
So,
simple language.
Yeah, actually, you can have early or delayed reconstruction, depending on the size of the tumor and the tumor pathology and the post-op management of the tumor. In patients who are going to have, for instance, radiation therapy, we'll advise them to have delayed reconstruction when the radiation has been completed, so that after the reconstruction, we don't have to go and radiate fresh tissues that were brought in to reconstruct the breast. So if there is a small tumor, and that depending on the tumor pathology as well, early or immediate reconstruction is advised. So they go in once to get the tumor removed and have a reconstruction.
Do you involve the patient a lot then in making a decision about whether they ultimately take an early or a delayed procedure?
We advise the patient, the patient should also advise us whether she's willing to do an early or delayed reconstruction. Some patients will say, I don't want to walk out of this hospital without a breast, so I want immediate breast reconstruction. Some patients will say, I'll wait until I'm cocksure that the tumor is completely out before I can opt for a reconstruction. So it's actually a decision that is made between the surgeon and the patient. But the surgeon should actually advise, on the safety of the procedure and the timing of the reconstruction.
Thank you very much for that incisive talk and insight into the breast reconstruction, Prof. Now, I would like to request Lilian, a veteran of it all, who has does all sorts of programs and campaigns around breast cancer, to really just have give us a final parting shot, an overview of the life of a breast cancer survivor, as a take home as we conclude this exciting webinar this morning. Lilian, welcome. Thank you very much. It is an honor to request you to come to the podium to just give us I know you have a long journey with this disease. Professor Ben did allude to the fact that you've lived for a very long time with it. But just in a summary, what would you say both to health workers to encourage them, like ourselves at various levels in the healthcare fraternity, as well as the NGOs that are doing all sorts of work to try to support, healthcare, support breast cancer care, and as well as to encourage, notable corporate citizens like Avon in the work that they are doing to support this important journey.
Yes.
Thank you so much, Dr. Molefi. It's an honor to be here. I must first of all thank all the doctors, the oncology, the nurses, everybody. I've never seen people who are so dedicated and they empower us. I want to thank my GP, who chose Dr. Carol Ann Ben. And when I got there, she thought it wasn't a big deal. She just made me sure that I'm not going to die. They have to be moved and there's no hurry. So when I went for surgery, that was in 2008, there was no fear. She removed the fear. Also, I joined a support group immediately, the bosom buddies. So I encourage all the survivors, anybody, to first join a support group, because people who've walked that journey know better. Even with radiation, when I got there, the people said, you must buy yourself Mircena. I didn't listen. I just listened to the doctor, only to find that they were right. So the reason I am grateful to have had cancer, even though it's not a nice thing, it has allowed me to reach out to people and educate them, create awareness, because I said to God, if you save me, I'm going to create awareness, because people don't die from cancer, they die from ignorance. So because of my role as Sister Bettina in Soul City, I knew what to look for. As a result, I have found my own lamp. Even the second cancer, I still found my own lamp. So the first one was a lumpectomy, and the second one, I had to go for mastectomy. And on the question of breast cancer reconstruction, I refused. I told Dr. Carol Enben, at my age, I've got no little children, and she was saying to me, you lose your partner. I said, if I have a partner who loves me for my breast, toughies. So I am quite comfortable. Sometimes I put socks in my bra or what, and I'm still beautiful. And so for me, personally, I think God was using me to create awareness. And here's my good friend, Ray Kasim, who's had I don't know how many cancers, but her job is to create awareness and to give people support. So really, early detection, early treatment does save lives, and cancer need not be a death sentence.
Thank you
So,
very much.
Yes.
No, so ma'am, the last word is there.
Okay, so I liked, as someone here, one of the speakers said, oh no, that was Professor Carol Enben, we shouldn't tell people about the negatives. For me, even losing hair was a blessing, because I didn't have, my hair and my other hairs down there, no expense, no waxing. And then I didn't have to wear my wig. I just went to work, put my big earrings and a short skirt. It was lovely. And also, look good, feel good. People give survivors so much love and care. So unfortunately, in my community, people don't even want to hear the word cancer. They will go down, cancer, as if you say cancer, you're calling for it. No. The reason people die is because they go when it's too late. When it's detected early and treated early, you can still live. That is why every year with Ray Kasim and the others, this is the month for creating awareness. That's why I've joined Avon Itemba for this walkathon. And then besides that, I belong to the Cancer Survivors, where we go on motorbikes from Joburg to Cape Town on motorbikes, creating awareness, because knowledge, when applied, is power.
Marilyn, do you think there's enough that is taught or spoken about personal sexuality and surviving or suffering from cancer in our
Thank
society?
you so much, Dr. Molefi. That is very important, because a lot of survivors complain of dryness. So if you ask your doctor or your support group, they know there are creams that you can apply. Because really, when you are a survivor, I only wash my panty because of hygiene. My panties are always clean. There is no discharge. So there's no lubricant. So that can be good for sex. So thank you for asking that important question, because some women that I know have become lesbians because they are afraid to be hurt by men, even though sex is the good thing. So people have got to discuss about sexuality, because it puts you off sex when you are a survivor.
Thank you very much, Marilyn. That was a good way to close it. To sum up, I would like to thank everybody, all our guests, our distinguished panelists, and our competitors within the civil society movement that are part of this event. I'd like to thank once again Avon for putting it all together and supporting this cause. I think all of us can attest to how productive and informative this session was. We do hope that in due course we should be able to host yet another one. As I said earlier at the beginning, this marks the beginning of International Breast Cancer Awareness Month. However, it also is a notable beginning of our campaign to support the Itembe Walkathon at the end of the month that is going to be hosted on the 31st of October, which is an event that is being hosted to reflect a standpoint of a full commitment towards supporting improved breast cancer, particularly to strengthen campaigns and strategies, driving increased early cancer detection. So let's do our best to support the call by extending the invite to our friends, colleagues, and everybody else in our communities. Together with STEND, and I'm sure the results at the end of having a successful virtual one, for that matter, this year is going to be extremely beneficial towards continued support of breast cancer care. And I thank you for your attention. Thank you very much for behind the controls there and driving this to make it the success that it was. And over to you. Are you there?
I'm here, Dr. Molefi. I think obviously looking at time, I think you've wrapped it up nicely for everybody, in this regard. So yes, we are done.
Thank you. Thank you for coming all, and goodbye.
Thank you, everybody. Thank you so much.
No, thanks for the opportunity. Thanks, Doctor, and all other people. Thanks, bye.
Oh, Minister,
Minister,
just before you go, I mean, your face was shaded off. I thought you had already gone to one of the important meetings. I just wanted to say, can you say something about a policy, just as a parting shot, about policy, perhaps initiatives to enable, education around blood cancer, perhaps maybe that we could adopt or work towards? If there's any comment in that regard, please.
No, Doctor, it will help because as a sector, we're upping our work around well-being and health programs. And I think it will really help to work with because we have a wellness or a health directorate to make sure that they also incorporate information about breast cancer, because indeed the awareness would help, not even when kids are affected, but even when their families or their parents have breast cancer, they will be able to really understand and support their parents or their siblings. I mean, we're 14 million learners, so we reach almost more than 6 million households. So it won't only benefit the learners, but it will even benefit those households where these learners belong to. So I would really love to link that, and I will link as I say, we've gone back now under level 1, Dr. Whittle, who is in charge of our well-being, of our wellness program, to see if they can incorporate this in our wellness program. I will definitely follow up, Doctor.
Thank you very much, Minister. And please don't close me off when I keep on getting in touch to want to talk.
No, far from it, Doctor. I really appreciate your communication and your contact. Thank you very much.
Thank you very much. Goodbye to all.
Thank you very much, Doctor.
Thank you.
Thank you.
Bye.
Thank you.
Bye.
Bye.
Mwah,
Bye,
mwah,
everyone.
mwah, mwah.
Thank you.